Good morning. Mike Kazinek. Come on. All right, guys, we've got 2 quick lectures today. We are not going to really, come on, go crazy because it's stuff that really you should kind of already have a general concept of, because it's primarily BLS stuff. So, lifespan development. I'm going to say make sure that you are very familiar with the various vital signs for everybody, for each age group. That is consistently a test question, not only on classroom tests but also the state. Can you guys hear me? How am I muted? There we go. I don't know how I'm muted. All right. Lifespan development. We are going to kind of cruise through this. This is my major, mostly BLS stuff. Make sure you are very familiar with the vital signs for different age ranges because it shows up for everything, okay? It shows up on all the different tests. A very sick young baby is unusual. Okay, so for the most part, babies will keep their mom's immune system for the first few weeks of life, right? Because they were swapping blood in the womb. So all those antibodies and antigens, they kind of just hang out for a little bit while the baby is very young. If a baby is breastfeeding, this will continue this protection. However, the baby will start to develop their own immune system. The thing is, if you have a very young baby who is very sick, that should be suspicious. They've caught something like really bad that mom has not been previously exposed to. Infants have growth plates, and they start to roll over around 6 months. So if mom, dad, whoever says, oh, the baby rolled off of the changing table at about 2 months or so, that's usually not correct. That should be suspicious for you. This right here, excuse me, is a picture of the anterior fontanelle. You can see that little dent. That is the last fontanelle that closes. It usually closes within 18 months. Some textbooks say 24, but it's 18. And most of the time, babies start to teeth around 4 to 7 months, and this is when they start getting grumpy, right? This is when they're a little unhappy because they're having, dental pain. It's not fun. Couple of different reflexes that babies will have that are not really adults, seen in adults. So you have the Moro reflex, which is also known as the startle reflex. So if you kind of like boo, right, the peekaboo game, and they go, wah, they will open their arms very wide and then spread their fingers like they're trying to grab something. You have the palmar grasp, so if you put anything in the baby's hand, they'll grab it. The rooting reflex, which is also kind of associated with the sucking reflex. So if you touch a baby's cheek, they'll turn their head, pretty much like they're looking for food. And then if you touch their lips, they'll start sucking, thinking that, again, like it's a nipple or some sort of bottle. Babies experience attachment as they start to, grow up. They want to feel secure. Some of the issues that happen are when babies aren't experiencing a safe environment, so they won't develop what's called a secure attachment, right? So if they cry, mom or dad will come and they, tend to their needs. What happens is they start to become anxious or avoidant, and this is what you see a lot with kids who are like in the foster care or from a very young age, or like orphanages, right? So like after a while they'll stop crying. There was an article I was reading that was talking about how, I think it was in Romania, one of the most sad and depressing things that this reporter had ever seen was that there were just completely silent infant ward. Like babies weren't crying; they were just laying there, feeling like they had developed this feeling of hopelessness because no one was attending their needs. Right? If they cried, no one came to soothe them. So it was very it's a challenging experience for a lot of babies if they don't have a positive psychosocial environment when they're starting to grow up. Babies can have what's called a temperament, right? So there's some babies who are easy, right? You lay them down, they take a nap, you pick them up, they're in a good mood, they coo, they babble. Or you can have a difficult baby, right? These are the colicky babies who kind of cry a lot and won't settle, won't sleep through the night. And then you have the slow to warm up babies who are kind of somewhere in the middle. I don't know why this looks so hard. So here's your normal vital sign range for toddlers and preschoolers. I don't know where the one for infants went. Um, so the top is heart rate. For toddlers and preschoolers, it's a little faster than we expect to see like an adult, right? So you have to remember that these smaller children are kind of like hummingbirds, okay? They have a small, weaker heart, but they also have a smaller body, so they can maintain this level of heart rate. They also have a faster respiratory rate, which is here in the second range, because they just, whatchamacallit, they have smaller lungs that are less developed. Their chest wall is a little more flexible. So when they take a deep breath like that, they don't get as much air or chest excursion. Then you have here is your normal systolic blood pressure range. Both of them are usually about 80 to 100. There's a formula. The textbook has a formula, what you should expect for blood pressures for this age range. And usually then you have the temperature range for kids. They sort of start to normalize. They'll be a little warmer when they're younger because they have a higher metabolic rate to maintain that really high heart rate. So as they get older and their heart rate starts to slow down, they will normalize in temperature. As kids get older, they start to lose passive immunity, which is all that immunity that they've picked up from mom. But what they start to do is they pick up their own immune protection. But these are the kids who, right, they go to school, they go to daycare, and they pick up every single infection known to man, mostly upper respiratory, right? Because they put everything in their mouths. Because now they have improved motor skills. They are better at figuring out, right, their hands. They're able to be a little more coordinated. Walking is a thing, running is a thing. These are those kids who are challenging to kind of wrangle, right? They want to just run around and play. Improve muscle mass, bone density, right? Their bones are starting to calcify a little bit, where they're a little less squishy, but they're still more prone to green stick fractures than a complete fracture. Toilet training starts happening. This is different in every child. Okay, kids need to be ready to be toilet trained. Some of them are like, yes, please get this soggy, gross diaper off. And some of them are just like, I'm afraid of this toilet. And kids also start to become very chatty at this age, right? They start to understand speech. But kids will learn speech as quickly as their parents and other adults in their lives talk to them, right? So the more larger words that adults use around kids tends to have younger kids with better language skills, okay? Rather than like, the baby talk. Baby talk doesn't help kids really develop language skills that great. Now you can see this sort of better. School age rate is from 6 to 12 years old. This is still prepubescent. They will start to grow pretty rapidly at this point. They'll get a few pounds and a few inches every year as they age. They start to get their permanent teeth in, and puberty can start. So puberty can start really young, and it's been happening a lot younger in the United States just based on the foods that we're kind of allowing ourselves to consume. There's antibiotics and growth hormones and stuff and everything. Obesity also, especially for girls. Obesity can trigger the menstrual cycle to start earlier. It gets complicated because the younger a at least a female, younger female goes into puberty, yeah, is also the younger that they will go into menopause later on. And the earlier you go into menopause, the more likely that woman is going to experience cancers and high blood pressure and cardiac disease in her lifetime. Kids also start to kind of develop an idea of who they are as a person, right? They have things that they like, things that they don't like. They start to understand right and wrong and how to reason a little bit better. They kind of get a better idea of how to be like a general human who we how we function really on an everyday whatchamacallit basis. That's the word I'm looking for. I need more caffeine. Again, the pulse starts to normalize a little bit more as these kids get older. It's 70 to 120. The respirations start to hit a range that's a little more familiar, right? It's 15 to 20. Blood pressure again, and the temperature's much closer. They go through stages of learning how to reason. We're not going to go really super in depth about this, but when they're younger, it was called the pre-conventional stage. And again, this is not a very consistent progression. It's sort of like the grieving stages. They could have various levels of this reasoning at any time. But most of the time, the pre-conventional stage, it's I'm going to be punished. I don't want to be punished, so that's why I'm not going to do it. Which kind of starts to transition into I want people to think I'm a good kid. I understand what right and wrong is. And then it becomes a little more abstract as they get into the post-conventional reasoning, which there are some people who honestly I don't think ever reach the post-conventional level fully, where they kind of understand right and wrong, ethics, the gray area of some ethical, reasoning. That's a very complex stage, and there's definitely some adults who never reach that stage. Teenagers, right? These are the people who are actively going through puberty. There is a massive surge of hormones and neurotransmitters and all sorts of other things that make teenagers kind of a little on the unstable side. Their body is changing. They're, just experiencing this huge influx of a lot of change that's going to make them uncomfortable. And on top of that, they start to experience like a little bit of self-consciousness because of these changes. And also like those sexual urges and stuff that start to kind of appear. Teenagers at this point have the same vital sign ranges that we would expect to see in an adult. When it comes to growth, it's really kind of crazy how growing happens. For the most part, when any creature develops and starts to grow, they start to grow from the outside in, which is kind of crazy. So you'll have these kids with like big, weird, floppy feet, and they haven't caught up to that quite yet. Nothing really that I don't think anyone has necessarily experienced before, right? We still dictate that puberty starts when we start to see pubic hair and breast development in children, underarm hair also. That's kind of when we've determined that they've hit that puberty stage. Teenagers have a lot of different experiences as they do have these waves of hormones, and they're experiencing these weird social constructs within school, right? Because who's trying to fit in, who's trying to make friends, who's trying to be popular, who's just trying to figure out who they are, right? It's a lot of things that makes it challenging for kids. Unfortunately, this is also when a lot of social pressures create a lot of issues, like like eating disorders and drug use and experimenting and They have a really underdeveloped prefrontal cortex in their brain, so they don't have great decision-making skills and all the time, and this is why teenagers tend to do a lot of stupid things. Um, it's just their brains trying to catch up with their body and their hormones. Early adults, you have that 18 to 40-year-old range. These are the adults who are quote unquote considered the most stable, which I think if we looked at society as a whole right now, it would probably be a giant lie. I feel like that stability period has kind of shifted based on our current economic factors and pandemics and all that other jazz. From 19 to 25 is when your body is supposed to work the best. Um, if anyone has had some optimal body performance at that age range, please let us know. But there's also a lot of different stressors that start to experience people start to experience in their early adulthood, right? You're starting a family, you're buying a house, you're getting a job, or you may be switching jobs. There's a lot of different stressors in this period. Vital signs are that normal anticipated range that we usually see. Middle adult is like when everything, personally, I think this is probably at this point in America anyway, is the more stable range. In so much as there's maybe a reduction in stress. This is when people are kind of set in their careers. They've maybe already developed, got their family underway. But this is also the part of life where people start to experience issues in terms of health problems. Cardiovascular, cancer, women experience menopause, vision loss, hearing loss, all of these different things that start to come on with age. Memory loss is not a normal sign of aging. There's a lot of research on how that's not a good standard for people to expect. There are plenty of very old adults in their 90s and stuff who have very sharp memories. So the fact that we kind of brush off oh, you're a little forgetful, as just a sign of aging is not necessarily appropriate. Again, your vital signs are stable in this age range. Late adults, 100% all of the vital signs as well as patients' ability to function depends on their health status, right? If they took good care of themselves, they will experience fewer health issues than a person who did not take good care of themselves, right? Overall, this is when the body starts to become kind of less pliable. So all of your function starts to decrease a little bit. Your heart doesn't work as well. Your blood vessels don't work as well. Your kidneys kind of start not doing as much as they want. The skin starts to thin because you start to lose collagen. So you're more prone to like stupid little injuries like skin tears. And patients at this age start to also experience like a decreased coughing and gagging reflex. So they'll experience things like aspiration pneumonia a little more frequently. This is why we see those patients in nursing homes who are having just pneumonia for no reason. Or patients who have just developed pneumonia, and you're like, what's going on? Probably that they're not swallowing as effectively as they were when they were younger. Again, vital signs, kind of standard adult, where we'd expect them. As patients start to get much older, you will see that the body starts to kind of slow and break down. So everything just starts to not be ideal, like in an ideal function. So you have less insulin production, so you might have higher blood sugar levels. Patients might start developing type 2 diabetes. As you start to get much older, like in your 90s, your kidney function starts to significantly drop off, which means it's harder for patients to decrease or eliminate their wastes and to manage their electrolytes as well, right? Because that's what your kidneys are really good at. Patients start to eat less because they always feel full because their GI motility starts to slow down. As your brain starts to just naturally atrophy, it has a little more space. So patients who maybe fall and hit their heads will have a little bit of a longer period of time before they start to exhibit signs of a brain bleed, even though they may have it, right? Because they have that extra space to hide blood. Patients aren't able to feel as well, like their peripheral nerves start to kind of deteriorate a little bit. They start to have issues when it comes to like concerns about finances or elder abuse or who's going to take care of them. All of their friends and family and stuff start dying, so they might experience depression secondary to like being the only one who's still alive. And they have what they call the terminal drop hypothesis. I know Vinny put this in the group the other day, where patients with dementia will have like terminal lucidity. For the most part, in the 5 years preceding death, you'll start to see patients who are otherwise very sharp and on point start to have memory issues and cognitive impairment. Not too bad, right? Lifespan development in a nutshell. Oh, Alyssa brought her cat. Hi, cat. So yeah, so if you have any questions or need clarification, definitely check the textbook, because I think the most important thing that you're really going to need to know is your vital signs for each age group. That's probably ideal. And anything that might have been mentioned in regards to lifespan development on the review sheet, it's something we talk about, but it's not something that like we really spend a lot of time on, because it's just having a general kind of overview. Any questions?
I have a question about the formulas, Nicole.
What formulas?
The math. The math.
Okay.
And so we don't have the answers, so I don't know if I'm getting the answers right. I was wondering if we can like go over like a question or two, maybe about I don't know. I think I'm good with the total weight over the total volume. I don't know, for some reason I feel like I'm getting it wrong.
Okay. I have one more lecture, so if you want.
Oh, okay, gotcha.
Well, no. How about this? Drop it in the chat while I'm doing the lecture, so then when I'm done with this next presentation, we'll do a few. How's that sound?
I got you. All right, thanks.
Then that way I can go find a calculator. All right, cool. So let's get to this last presentation, and then we'll do a little bit of math. Come on, I want to switch. There we go. No. All right, again, patient assessment. You guys should all be pretty good at this so far. The main thing with patient assessment is that you're now going to start building a more thorough patient assessment skill toolkit. So there's one of these things that's kind of interesting. It's called System 1 versus System 2, where System 1 is like that gut feeling, right? You walk in and you're going, that patient's very sick. I'm going to have to do something about that. Whereas System 2 is kind of more what they do in the hospital, where they're like, we're going to investigate, send them to CT, let's draw blabs, let's do this. They've actually found that very automatic kind of diagnosis, like that gut feeling diagnosis, is right like 75% of the time. So if you have some sort of gut feeling that even if the patient looks okay, but there's something off, stick with that gut feeling, because you might actually be really right. And that is kind of built off of experience and repetition. So the more patients that you see and the more pattern recognition that you start to develop, the better your System 1 processing and System 1 diagnosis is going to be. 82% of the time. So using System 1 versus System 2. This is attending physicians, right? But I think that we in EMS also are going to see, have enough knowledge that we can probably be just as accurate. But they only got these physicians were provided with demographics, chief complaint, a method of arrival, vital signs, a past medical history, and a medication list. and they were asked to determine if the patient was going to be discharged or admitted, and they were correct 77% of the time. This is what we do, right? We do a sick from the door. This is our doorway assessment. The sick versus not sick. Is the patient really ill? What's going on? Is there some sort of if there's some sort of like issue with the patient that we can 100% see, right? Color is off, they're breathing rapidly, maybe they're diaphoretic in a normal temperature room. These are things that we kind of can see from the door, and that kind of guides most of the time our speed with which that we start taking care of the patient. So the field impression is what we believe is the patient's current problem, not what the patient necessarily tells you, right? So the patient might be sitting there going, "I'm having shortness of breath," but they're clutching their chest, and you're kind of going, "This is probably cardiac related," right? So this is what we start understanding as we put all the pieces of our knowledge puzzle together, and it's going to depend a lot on the questions that you start asking the patient, right? You need to kind of tailor it to what the patient is experiencing, what you see, and what information you think is going to be helpful in making your differential diagnosis. A little note on medical versus trauma. So your medical assessment is going to require a little bit of a deep dive into the patient's medical history and the history of their present illness, where in trauma, their medical history might be less important, but still could be impactful when it comes to what's going on with the patient. Most of the time, that's the patients who are like on blood thinners or fragile diabetics in trauma who you're going to anticipate are going to do poorly. Now, from the top, scene size up. When you're trying to evaluate for your scene safety, make sure that you don't get tunnel vision, right? You want to look at the whole picture. Like for example, like if you look at the videos of the Times Square shooting from a couple days ago, you know, as an EMS provider, you don't know where the active shooter is. So you want to make sure that you are keeping your head on a swivel, that you're making sure that people running at you aren't armed, so there's a lot of considerations that you want to, take. When it comes to things like crashes and rescue scenes, there's a lot of different components at play, right? Cars might be unstable, something might be on fire, metal, glass, all sorts of things. The possibility of fire always exists. So you need to make sure that if you are on a scene where it might change dramatically, that you're prepared, you're far enough away. Remember the thumb rule. If you can't block the scene with your thumb, you're too close. Just something to keep in mind on some of these more precarious situations. Access and egress. So how are you getting in and how are you getting out? You should have a plan of action for both. It might not necessarily be the most obvious. This is also going to be dependent on the other resources coming to the scene, right? If someone's blocking your ambulance, before they get out of their apparatus, tell them to move, right? Because if you have a patient, especially on fire scenes or crash scenes or something like that, if you have a patient, you need to go to the hospital, you don't want to have to go find the chauffeur to move the engine that's now blocking your line of egress. So sometimes it's worth it to park maybe a little bit further away from the scene and hoof it, because you need to know that you're going to be able to get out. You also need to know that, in the event that there's something else going on, that you're going to be able to get out. There was an incident in the city earlier this week where a patient was stabbed in a public place. He was in traumatic arrest, and when it had originally come over, the call type came over as a stab. So the crew logically brought in a stair chair. Patient ended up in arrest, and before they could get a proper moving device, the scene became hostile. So they got the patient in the stair chair and got him out to the ambulance when they were proceeded to render care. So these are things that you need to make sure that you're keeping an eye on. Is your scene safe, and can I take my patient with me if it does become hostile? Strategically plan, right? So if there's a car accident in particular, like you can have other apparatus protect you. You should also make sure that you're parking your ambulance strategically in a way where you can get off of a scene and you're not being blocked in. Again, something like this, perhaps you're parked, perhaps you're parked a quarter mile up the road a little bit and you're walking back to the accident, because that way you won't get blocked in and you're not stuck behind like all these trucks in the background. Crime scenes are always very dangerous. There's always the possibility that more violence or hostility will erupt, just like that stabbing I was talking about. If the scene starts to go south, you should go out. Just don't stick around. It's just not safe. Drugs are always fun. Patients are taking a variety of new and exciting combinations of things these days, but those patients can be particularly unstable, right? They might be unpredictable in their motions, in their actions. They might act out violently, even though like there's nothing necessarily like making them do so. So always be aware. Your physical environment also always a concern. I know during Sandy, my husband ended up getting stuck in the sand down the Rockaways. He spent 16 hours in his ambulance stuck in the sand. Flooding, snow, ice, all these things. If you see a puddle and you're unsure about how deep that puddle is, don't drive through it. People make that mistake all the time. Just don't do it. Extreme heat is also always dangerous, right? If your ambulance overheats, you overheat. You're not exactly wearing like, shorts and a t-shirt. You're out there wearing navy blue. It's going to be extra hot. MOI or NOI, right? This is pretty basic. MOI is your mechanism of injury. Excuse me. This is how a traumatic injury occurs, and we're going to talk about this when we get a little bit more when we get to the trauma section. But there are a lot of factors at play when it comes to a traumatic injury and how the body responds and the injury patterns that you're expecting to see. This versus a nature of illness, right? Which is like you're sick. What kind of sick are you experiencing? Sometimes it's super simple and straightforward. Sometimes it's a little more complicated. If it's wet and sticky and not yours, please don't touch it. BSI. I think we're all kind of sick of hearing about BSI at this point. I think we all understand that we need to make sure that we're well insulated from other people's crap. But this also means that like heavy objects, sharp objects could also be an issue. So always make sure that you check your gloves. I can't tell you a number of times like you're rendering patient care and like your glove snaps. You're like, oh, well, time for a new glove, right? So just keep that in mind. Primary assessment, general impression. All right, so looking at this patient, what is your general assessment?
Oof, he's fucked.
Oof, right? Oof's a good, it's a good observation. So we've got what looks like bilateral double tourniquets on this patient. So significant bleeding. So he's probably in a shock state, right? He's covered in blood. He's got significant deformities to both bilateral tib fibs. Immediate thought of what probably happened.
Crush injury.
Crush injury.
Do we know what took those chunks out of him? He's missing some pretty deep chunks.
He is
I
missing
think
some
like
pretty good
in
chunks.
a ditch or something, because it's only his lower extremities.
Yeah, exactly. So right, so he
Up or
only has
down.
lower extremity issues. So either he got crushed, his lower legs got crushed, his lower legs got hit by like a car, because maybe he's got bumper injuries from those crushes, or maybe he got attacked by a shark. I don't know. He is missing some pretty significant chunks right there. But yeah, like that's significant. But would you also be suspicious potentially of abdominal injuries for this patient or chest
Yeah.
injuries, right? So exactly. So you can't get tunnel vision just because he's got these gruesome leg injuries. We don't want to necessarily skip the rest of our assessment. On top of that, you want to make sure, right? So clearly he was having a life threat, right? He was bleeding so significantly that they put not just one, not just two, they put 4 tourniquets on this guy. So he had significant bleeding. So would you consider this patient stable or unstable?
Unstable.
Good. Stable or unstable?
Dead.
Dead.
Unstable.
He's very stable. He's not getting better.
He's stably
Yeah.
dead.
He's stably dead. Would you transport this patient?
No.
Nope.
What happens if this patient
Well,
still
City.
had a What happens if this patient still had a pulse?
How many other patients are there?
That's a good question. But what happens if he still had a pulse? How would you transport that?
Hope and pray.
Package as much as we can.
With a spatula.
Yeah, he's missing
We don't.
most of
We
his
don't
leg.
carry shovels.
We
I
don't.
need a spatula.
That's what a backboard is for, a spatula, right? Stable or unstable? What's your general impression?
Unstable.
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 Severe accessory muscle use.
Right? Tripoding. Look at his shoulders.
He
Yeah.
was a smoker.
Most likely, right? He's got that COPD look on him.
Barrel chest.
That barrel chest, the skinny limbs. Stable or unstable?
Stable.
Right?
From what you can
I
see.
would say have a high index of suspicion because they could decompensate really quickly.
Yeah, but would a child who's gonna decompensate be this color? Would they be
No.
Would they be this active and this engaged as
They'd
with
be
their
more
environment?
ashy.
They'd be more ashy. They'd be more sleepy looking. So if you walk in and you see a kid who's like, that should get your pulse rate going a little bit. You walk in, you see this kid, you've got some time to do an assessment, make the kid feel comfortable, and not really, you don't have to panic. There's no worry here. But good. Expose the patient as necessary. Right? Even BLS, I think we don't do this well enough anymore. A lot of people, BLS, we teach you, old trauma patients need to come in naked. And there's plenty of people who don't do that. But if you don't see the problem, you can't fix a problem. But you also want to make sure that you're keeping that patient warm. So if you're going to expose them, do it in the ambulance and make sure that you wrap them back up after you're done evaluating them. A quick review of your AVPU scale. Okay, we did this before, but your patient's awake, oriented to person, place, and day is alert and oriented. If their GCS that usually means their GCS is 15, unless of course they have some sort of pre-existing issue, right? They might have a developmental or mental disability. They might have, dementia. They can still be considered alert if they're at their normal baseline. You need a family member to confirm that that is their normal baseline. Then you have patients, right? The verbal stimuli, they're usually around a GCS of 13. Painful is usually a GCS of 8, and unresponsive is 6 or worse. Okay, so just keep those numbers in mind to kind of give you some milestones because they love to ask GCS questions. Airway. So we're going to start adding a few things to your airway assessment, right? So obviously the most important thing that we talk about in BLS is the airway open and the patent. Do you need to do anything in order to ensure that the airway remains as such? But now as we're moving into ALS, you're going to potentially look at things like the Mallampati score or the patient's airway anatomy, such as the thyromental distance. So if you can put 3 fingers underneath a patient's chin where you're touching like their Adam's apple kind of area, and you're underneath the chin there, if you can put 3 fingers, usually that patient is going to be a relatively easy tube because you have enough space. If it's 2, 3, and like inside the mouth is 3. That means that you have enough space to work, okay? It means you have the space to move the tongue out of the way. You also have the Mallampati score, which they use, right? So an easier airway is going to be class 1, where you can see the uvula in the back, you can see the opening of the airway, you can see all of those things. Whereas a class 4 is going to be probably more difficult because you can't really visualize as well. It means the patient's going to have a larger tongue. Some things that are going to help you when you're looking at an airway, of course, we love our acronyms. So this one's LEMON. So look, is there anything in the patient's external features that is going to indicate that there's going to be a problem, such as facial trauma, like big teeth, A really large tongue, and trust me, you know, right? You got those patients with like a really large tongue. You can evaluate, or again, we talked about this already. So you have incisor distance, which is inside the mouth. So if you can get like 3 fingers in, you'll be good. Hyoid mental distance is 3, which is again, this is here, and then thyroid to mouth, which is this way. So it should be 3, 3, 2. To make it, that'll be the easiest airway. Mallampati score, right? It should be easier. A class 1 or better, or class 3 or better is good. Class 4 might be a challenge. Is there any possibility of an obstruction? Where that's kind of ties into look a little bit, but it now adds in medical issues such as epiglottitis. And how mobile is the neck, right? Do you have a real elderly person whose neck doesn't really move? Do you have someone who maybe is in one of those soft collars because they had some sort of neck issue, right? So that's going to impact your airway. So just a little review of, right, here's your pediatric all the way on the left versus your adult airway on the right. You can see how the tongue sort of changes in terms of the space that it takes up in the mouth. The airway in a child is also much softer, so it becomes a little harder to maneuver, whereas the adult airway has a little bit more structure. Breathing, right? So is the patient breathing, and is it adequate? We say, right, chest rise, but just because a patient has good chest rise doesn't necessarily mean that they're breathing great. The patient also should be breathing quietly, right? They should not be really straining to breathe. The rate shouldn't be really fast or really slow. A good rule is if you're breathing comfortably and you can match the patient's breathing, they're probably breathing adequately. There's a lot of different things that can impact how a patient breathes. Rib fractures, pain, muscular issues such as like a muscular dystrophy that might affect these thoracic muscles, PEs, right? There's a lot of things. So you want to get a good initial assessment of their breathing to determine if you need to do anything. Circulation, right? Do they have a pulse? Always good to check. Your skin color, temperature, and condition, this is always going to be a little bit dependent upon whether or not the patient is in an environment or a good environment, right? If they're in the cold and their skin is cold, I'm not surprised, okay? If they're in the hot and their skin is cold, that's a problem. Is there any bleeding? Capillary refill is really good for pediatrics. It gives you a good assessment, right? It should be quote-unquote brisk, which is 2 seconds or less to get that pink coloring back. Neuro eval, always good to do, especially if the patient has any sort of like vague complaint. In the city, they use the SLAMS score now, which is they use the face arm grip. I've just had a troll brain for it, right? So
Weakness.
Weakness, thank you. So
Grip strength.
Yep. So they're making sure, right, if the patient has facial droop, if the patient has significant arm drift on one side, a grip, slurred speech is the other S. That's not in here. If they have a score of greater than 4, it's a very high sensitivity that it's going to be a large vessel occlusion. In the city, those patients need to be transported to a primary stroke
LVO.
center. Yep, and for an LVO. If you have some reason that you need to restore circulation, obviously we kind of go back to BLS here. We're going to treat the patient for shock. The easiest thing, you're going to elevate the legs, give the patient oxygen, and you're going to keep them warm. If for some reason they are in a dysrhythmia, right, if we're going to talk about the more the current dysrhythmias with a pulse when we get into cardiology, but defibrillation, right, for VFib and VTAC to hopefully restore your circulation. Trauma patients, you do your rapid head to toe, okay? This is also really good to use for patients who may have been unconscious due to a medical. You still want to make sure that there is no sort of injury going on as well. Rapid, right? You're going to use all of your senses to perform your rapid exam. First of all, you're going to use your eyes to inspect. You're going to use your hands to palpate and your ears to auscultate, right? So you are going to do a thorough exam of this patient. Two most important details to obtain is your patient name and your patient's complaint. That's a textbook state question. Patient name, patient complaint, chief complaint. Those are very important. Why did the patient call 911? What was bothering them so much today that they were like, hey, I need to call an ambulance, right? Sometimes, a lot of the times, you're going to end up with patients who have very vague kind of complaints, and those are the ones who you're going to have to know how to kind of dig a little deeper and very carefully extract what's going on with them. We talked about this in therapeutic communications a little bit, right? So open-ended versus closed-ended. So if you need to maybe redirect a patient from like a rambling story, you can use closed-ended questions, yes or no. Do you have chest pain? Are you having a hard time breathing? Do you take your medications like you're supposed to? As opposed to open-ended questions like, well, what's going on today? What's bothering you? You need to represent yourself in a professional manner, okay? That means that you're going to be clean, you're going to be well groomed, you are going to come in with a positive attitude, because trust me, you will not get information from a patient if you come up like, oh, why did you call? Why am I here today? Patients don't want to deal with that. No one wants to deal with that. That's kind of rude, honestly. And don't be condescending, right? If the patient's like, I really don't feel good. Well, what do you mean you don't feel good? Okay, sweetheart. Like, stuff like that does not help. Doesn't promote a good relationship. That's what you're building with these patients. You're building a good relationship. Sample and OPQRST, right? It gives you a lot of information. It gives you a good spot to kind of also start building your question toolkit. So there's a lot of different questions that you can ask a patient, and these are all some of the topics that you're going to ask them about. Other things that are going to be helpful, right? Have they been exposed to any hazards, right? What's their occupation? You have a patient who says, yeah, I work with chemicals and now I'm having tingling in my hands. Okay, is there any possibility you were exposed to chemicals? It might be an anxiety attack or it might be a chemical burn. So things that you need to kind of investigate. Any recent hospitalizations? Oh yeah, I was at the hospital last week and they told me I have a kidney stone and now I'm having flank pain. Okay, so just a lot of things that you could consider. When it comes to trauma patients, these are some of the level 1 high trauma patients that really should be need to be brought to a trauma center. Remember, distal versus proximal. So when you're talking about penetrating wounds to proximal extremities, that's the humerus or the femur, nice and high. Also, any proximal long bone fracture, again, humerus or femur. Other things that you might want to make sure that are being taken in consideration, especially when it comes to kids and trauma, was a child properly secured in the proper age-appropriate seating device, right? So little babies, I think they've just extended it up to 2 years old, should be in rear-facing car seats. After that, they can be moved to a forward-facing car seat. Kids under, I think it's 100 pounds, should be put in a booster seat. I know some adults who should probably still have a booster seat. And what's the inside of the car look like, right? So you see right there, there's a bent steering wheel. That means that person probably hit that steering wheel with significant force. That person probably has pulmonary and/or cardiac contusions and really needs to be treated carefully and brought to a trauma center. Australia and New Zealand does this really kind of interesting public service announcement thing, which is this gentleman over here, where they talk about how seatbelts save lives, and they actually show the pictures of people with their seatbelt bruises after significant injuries or significant car accidents, wherein they actually somehow survived because they didn't have, because they were wearing their seatbelt. General symptoms that patients might experience that kind of could be almost anything. Weakness or flu-like symptoms. I think we might be familiar with all of those at this point. Night sweats, weight variations could all be a sign of chronic illness or poorly managed illnesses. Skin, hair, and nails, right? Rashes and hives are probably some of the most significant and emergent for us, where we could actually treat that. Jaundice is a long-term liver issue. Itching, pale, and skin and sweating is something that could be indicative of a bigger issue. Musculoskeletal, a lot of different things. Clubbing of the fingertip beds, significant sign of chronic respiratory issues. Any sort of loss of motion, especially after like a traumatic incident, right? That patient could have a dislocation or a fracture. The head, ears, eyes, nose, and throat, right? You're going to do a general quick look unless the patient has some sort of complaint. Loss of consciousness is always good. Any sort of severe headache should be investigated a little bit further, right? Does the patient usually have a headache? Does the patient have migraines or something like that? It might be an issue. Especially if you have a patient who's got some sort of neurological issue going on, like maybe they're having a weakness on one side or the other. Ask them about their vision or any vision changes. I've had a patient who had a dissecting AAA who had loss of vision in one eye. Okay, so that's usually, strangely enough, one of the most significant signs of a dissection, especially one that's a little higher up. Endocrine system, right? So you have lump or swelling in the throat, temperature intolerances. The big ones here is the polydysbia, aphasia, and polyuria, which is usually indicative of a diabetes. Patient may or may not know that they have diabetes. So that could be a sign. Chest and lungs, right? Dyspnea, coughing, and wheezing, chest pain, all of these things should have a high index of suspicion that there's something significant going on. They sometimes hang out with each other, sometimes they don't. Sometimes shortness of breath could be indicative of a cardiac problem. Sometimes chest pain could be indicative of a respiratory problem like a PE. So, just make sure that you're investigating those issues. In terms of bruising and stuff, bruising is commonly, random bruising is usually tied into anemia. Patient will also potentially be complaining of things like fatigue. Anemia can also be secondary to a cancer. Okay, so lymph nodes, again, I think everyone's mom, as you're a child, they would feel your lymph nodes like, oh, is it swollen? Are you having like an infection, right? Your lymph nodes are really good at filtering out infection from your blood, bacteria from your blood, so that's usually their job. But they can also be kind of hijacked by cancer as well, lymphomas and stuff like that. Good questions for your GI tract patient complaints, right? Nausea, vomit, diarrhea. That's my NVD down there. That can do a lot. I almost always ask my patient when their last bowel movement was and if it was normal for them, because that, a lot of times they'll be like, yeah, it was a little dark, and they'll have some sort of occult GI bleeding going on. So things to kind of take into consideration there as well. Urinary habits, okay, right? Is there increased frequency of going to the bathroom, especially in females? That's usually a good sign of a UTI. Men, less commonly so. Erectile dysfunction, mostly just secondary to erectile dysfunction medications. Testicular pain can be a surgical emergency if there's some sort of torsion. Things that we don't talk about enough is just the unilateral ovarian-like pain could also be an ovarian torsion, commonly missed, and women experience a lot of issues. You have a good question to ask women: when was their last menstrual cycle, right? Do they have any abnormal bleeding? Have they been bleeding for an extended period of time? I watched 2 EMTs bring a lady in who she'd had a DNC, and which is a délage and curettage. They basically scrape the inside of the uterus clean. She'd been bleeding for 3 months straight. She was hypotensive, and she was probably about the same white as the background of this slide. And they wheeled her in a wheelchair because they were trying to walk her in and she couldn't. But no one seemed to give, a damn about the fact that she was actively bleeding. Yep, IUDs, other birth controls are helpful to ask questions about what kind of contraceptive. Do we use our contraception correctly? Okay, generally, if women are on the pill, they're supposed to be taking them every day, not just when they're having intercourse or unprotected intercourse. That's a consistent thing, and it's a problem that somehow people get pregnant even if they don't necessarily want to. A lot of different things can happen neurologically. Seizures, new onset seizures should usually be high index of suspicion for you. Either the patient's got low blood sugar, or they've got a brain tumor, or they've got usually low sodium is another one that can cause random onset of new seizures. Syncope, any syncope where the patient passes out and then wakes up with a shortness of breath is a PE until proven otherwise. Just a good rule of thumb. And take that one very seriously. Syncope also can be a sign of a complete heart block, which we'll talk about a little bit more when we get to cardiology. If the patient has some sort of memory issues after like an incident, especially after a trauma, muscle twitches and tremors could be along, chronic illness like Parkinson's, or it could be a new onset of something else. Your electrolytes, especially sodium, can really impact the neurological system. Psychiatric disturbances are always my least favorite kind of call type because those patients are just unpredictable. Affect, right, is usually like the facial expressions. One of the things that's kind of really interesting, schizophrenia is usually caused by dopamine imbalances. Another problem that's caused by dopamine imbalances is Parkinson's. If you look at patients who have schizophrenia and patients who have Parkinson's, especially very progressed Parkinson's, go look at pictures of Michael J. Fox recently, they have a very flat affect where their face is just very unemotionless, right? There's nothing really going on in terms of their muscle, the facial muscles making expressions. It's because dopamine controls both of those, and both of those are being skewed by the neurotransmitter issues. Paranoia, right? That's always fun. Patients who are paranoid and also super self-aware that they're paranoid are probably the best because they're like, I know something's going on and I don't really know what it is, but I think it's also my brain playing with me. Hallucinations, patients very commonly will have auditory hallucinations before they have visual hallucinations. So visual hallucinations are a little more significant. A lot of patients experience anxiety, suicidal and homicidal ideations. Do you have any thoughts of hurting yourself or others? Always a good question to ask. You're going to start developing a better kind of grasp of clinical reasoning and how what you see going on with a patient can lead to something, right? This is the detective work that we start to do as paramedics. You're going to look for the inconsistencies in a patient's story and their symptoms, how they're saying, oh, I feel great, and their blood pressure is 70. It's important that you don't get tunnel vision, though. It's very important that you make sure that you keep a wide scope on a patient until you've got enough details to really start to narrow in your diagnosis. A lot of people are not as good at this as I think they used to be, mostly because we spend a lot of time texting. But it's good to encourage the patient to speak to you. You have to be patient, though. Don't rush patients along when they're trying to tell you what's going on with them. Sometimes you have patients who are not able to speak quickly. So just make sure that when you are talking to a patient that you are calm and collected and doing a good job listening, okay? A couple different things. Check this out more in your textbook for the details. There might be a question or two. I didn't really look at the test, but they usually be like, if you ask the patient to provide more info or ask them anything else you can think of, what kind of communication is that? Facilitation. That's just things that you should look at there. Some sensitive subjects. I've had medic students in the past not believe me that if you ask a patient what drugs they took, that they will pretty actively tell you. Once they understand that you're not the cops and you're not going to arrest them, you ask them what kind of drugs they did, They're like, oh yeah, no, I did some heroin today. You're like, oh, okay. Sure, no problem. Is that the usual amount of heroin that you do, or did you take a little bit more? No, it's my usual. Okay, is it your normal dealer, or is it a new guy, right? Because maybe that new dealer cut it with something new. Alcohol, always have a high index of suspicion, especially if the patient tells you they had 2 drinks. That was the first drink and the last drink. They don't talk about all the drinks in between. Or that drink could have been an entire handle of vodka. People are a little squirrely about telling you about their alcohol use. Abuse, right? A lot of patients won't necessarily talk about abuse. Sexual history, again, some patients are really open about it, some patients are not. If you have teenaged patients who you suspect have some sort of sexual thing, try to get them by themselves to discuss it rather than in front of their parents. Being a culturally competent paramedic is really dependent upon you and kind of being understanding and open-minded and understanding that not everybody has the same exact beliefs as you do. If you work in a highly diverse area, which if you are in New York City is going to be almost anywhere, you have to understand that not everybody is going to be 100% of the same beliefs. They might have different religion, they might have different cultural backgrounds, they might have different education or religion, and that's okay. That's what supposedly makes America great, is that we accept everybody for that. The acceptance probably needs a little bit more work, but hey, that starts with one person, and that person can be you. A number of different challenges that we may experience when it comes to collecting your patient history. The patient might be experiencing a whole number of different things like anxiety, confusing multiple symptoms. They might not want to talk. They might want to talk too much. You will learn how to manage all of these things. I feel like you probably already have a relatively good way. The best thing is make sure you don't get frustrated. Try to be as patient as you can. Different age-related considerations, right? Pediatrics, don't be dismissive of them, but you do need to make sure that you get the right story. This is also going to be really dependent on the lifespan development age of the child. The older the child is, the more that they're going to want to contribute to the story and tell you what's going on. Kids under 5, febrile seizures are super common. If a kid has any sort of complicated medical history, the parents are going to tell you and probably will be well informed about that than you are. And always ask for a maternal health history when you have any kid, especially under the age of 2. Were they full term? How were they born? What was their birth weight? Were there any complications? Did they spend any time in the NICU? Geriatric, there's a number of different complications for that as well. Right, most of the time it's hard of hearing becomes an issue, where you're trying to talk to the patient, they're really not able to hear you. Chronic comorbidities, right, a lot of different things going on, medications that might overlap and cause different issues as well. Medication changes can cause a lot of problems, and a lot of older patients are kind of scared of going to the hospital because they're afraid they won't be coming home.
Hey, Nicole.
Yeah, go ahead.
I just want to interrupt and say, like, please, everybody, listen to your patients and your patients' parents. I have a child who has severe asthma, and every time she's been intubated, it's because they did not medicate quickly enough. And this was like prior to, like, now she has her own epi that she carries, but prior to that being sort of protocol, the ambulance would show up and they'd be like, oh, but she's satting at 100. It's okay. I'm like, no, but it's not. She needs mag, she needs dex, she needs epi, she needs it now. And every time she's ended up intubated and on a ventilator in the hospital has been when that stuff didn't happen fast enough. So when people are telling you that their kid goes down fast, they're not being dramatic. They're really not. And same with older people. Like, you really do have to. I think we tend to think we know better, and the few times that she's, the 5 times she's ended up in the ICU for days have been like just not medicated fast enough.
Yeah.
And I've been like banging my head against a wall because I knew it could have been prevented. So
well, good news. Now that you can probably access a lot of this medication too by the time you're done with this class. You'll be able to fix it yourself.
You are 100% right. Well, and now people, now like it was part of what got me into EMS was dealing with her. So like now I find people listen to me, right?
And once, yep,
Like
once
there's a
you
different
know,
level of whatever.
yeah.
You know, she had a, bad asthma attack up at school, and I got on the phone with the EMTs. I'm like, you need to do this, 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 and this. And they were like, here are the paramedics, and they were like, okay, like, and they did. And you know what? She was fine. So you do have a different level of respect at this
It's
point,
true.
but you're absolutely right. But I just, you always feel like you do feel like you know better, and sometimes you don't.
Yeah,
So,
sometimes it gets a little sideways.
yeah.
All right. So your secondary assessment, right? This is when you're starting to kind of collect more information, quantifiable information. So your vital signs, the survey, things that you've actually found. Also, always take the patient's stated overall health with a grain of salt, because they're like, I'm in great shape, and you're like, but you don't really look like you're in great shape. Sometimes the things that you find are a different story than what the patient's telling you. Inspect, palpate, percuss, auscultate. We don't percuss all that much because it's just too damn loud in an ambulance. When you're acquiring your vital signs, don't forget that when you're doing your respirations and pulse, you should be determining the rate, regularity, and the effort, the quality and location of a pulse. And make sure that just because, and I think Beth just had the best, just because a patient's satting at 100 does not necessarily mean that they're getting that oxygenation. There's a lot of different things that can influence how well that the 100% oxygen satted oxygen can now release that oxygen to the end terminal organs. So that can be complicated. Your focus assessment, right? The patient saying, I'm having hand pain. You should be doing a focus assessment of that. Your mental status, okay, right? We talked about this a number of times. One of the cognitive functions things that they say in the textbook is ask them to add 7, do serial 7s. I think that's, you go to tell them to subtract 7 from 100 and keep going down. I don't think I could do that after like 3 or 4 7s. So maybe have patients spell easier words backwards to see how good their cognitive function is. We talked about a lot of this already, right? Clubbed fingers is like, that's a good example of that right there. What's going on with their skin? Significant hair loss can be a pretty indicative sign of things like endocrine issues. We talked about this as well, right? So you want to do a thorough evaluation. Kids who have hydrocephalus, there's the word, might have a shunt. You might see a tube kind of coming down right behind their neck. Battle signs, raccoon eyes, there's an example of raccoon eyes there. Missing or broken teeth. If a patient's is relatively healthy, it's pretty hard to break and or lose a tooth. So that should be a high index of suspicion for a bad mechanism of injury. C-spine, if the patient's having neck pain, take that patient's word for it, even if it looks like an III, gycoitis. You can palpate the spinous processes of the C-spine, so make sure that you do that before you put a C-spine on. We talked about all of these things already. This is just another quick reevaluation, right? You should be able to hear good lung sounds. The chest should be intact. There shouldn't be anything moving opposite. There should be no crepitus. We're going to get into heart sounds when we get to cardiology. That's another thing that you should check. Various breath sounds. Highly recommend that you go onto Littman and listen to the different lung sounds again, just as a refresher. Get your lung sounds on every single patient, because that is essential. You need to kind of develop that repertoire of knowledge. This is covered in your textbook. We don't talk about this in skills labs or anything like that, but this is like bronchophy, for example, is a residence over an area of consolidation. So if you have the patients talking to you while you're listening to lung sounds and you can clearly hear the words, it's a good probability that the patient has some sort of pneumonia right there. The same thing with whispered pector. Nope, too much words. Lub, dub, right? Your traditional S1, S2 heart sounds is actually the sounds of your valves closing, right? As they hit each other, as they close. So your lub sound is the mitral and tricuspid valves closing, which are the valves inside your heart. And then the dub is the aortic and the pulmonic valves closing, which those valves are actually technically inside the aorta and the pulmonary artery, respectively. Sometimes the heart sounds might have splitting. This can be pathological or physiological. It's like you have a lub-a-dub or something to that effect, instead of a nice lub-dub. Sometimes it's caused by your breath, because as you take a deep breath in, you increase intrathoracic pressure, and it changes it changes the pace of your heart a little bit. S3. S3 is always pathological. It is a great sign of systolic heart failure. It's Kentucky, lub-a-dub, lub-dub-dub, lub-dub-dub. Okay, so basically you have an overly compliant left ventricle, which causes this sound, and it's caused by passive filling, as opposed to S4, which is Tennessee, lub-a-dub, lub-a-dub, lub-a-dub. It's also usually pathologic, but usually it's caused by a very stiff left ventricle. So it's sort of like hitting a cement wall rather than hitting like a wet paper bag, if that makes sense. Other things, know that your corticough sounds when you're taking a blood pressure, when you're listening for the 4th and the 5th. Sometimes that pops up as a test question. A bruit is an abnormal whoosh. You usually hear that over a carotid, and it's usually indicative of turbulent blood flow, which means that the patient would be at an increased risk of a stroke because of calcification buildups. We don't really listen for murmurs, but we can. JVD, right? You're going to have a big engorged vein, jugular vein, and a thrill is usually felt over. The easiest way to find a thrill is over a dialysis shunt. Here's your abdomen, I think, for the 15th time. Right, you're going to assess for tenderness, rigidity, swelling, guarding, the different types of pain. You have your visceral pain, which is usually an obstruction and stretching of a smooth or hollow organ. So kind of cramping, right? So when you have like a bad stomach pains or something like that, that's considered visceral pain. Versus somatic pain, which is sharp and localized, and usually it's like a muscular pain or like a skeletal muscular pain. And then you have referred pain, right, where it's being transferred to a different area, usually associated with gallstones. So that gallstones goes up to your right shoulder. We talked about testicular torsion. Priapism is usually a good chance for some sort of spinal insult. Pregnancy complications in the female. Ectopic pregnancy should be high on your list all of the time. And hemorrhage, right? Because thank you. Hemorrhage is always high on your list because, right, obviously uteruses bleed, and you can't really control it very well. So you have the differences between a pathological fracture and a physiological fracture. A pathological fracture means that you have applied a normal force to an abnormal bone and caused an issue. So this is you step on on a person who has osteoporosis, right? They step and their bone has a fracture. Versus a physiological fracture where usually it's an abnormal force applied to a normal bone structure. This is any injury seen on a football field for the most part. Some more examples of various injuries. It's always fun. Peripheral vascular system, you want to make sure that you're evaluating this patient for the P's, pain, pallor, paresthesia or paresis, poikilothermia, which is a coolness, and also pulselessness. Usually that's a very good sign that there's some sort of vascular obstruction and a decreased tissue perfusion. Sometimes this can be caused by a number of different things as well. It could also be like a lymphoma or lymph issue, just a number of different things. Pitting edema, right? So you can grade them differently. Depends on if you push into the edema, it should kind of briskly refill at a 0, which is like a normal. If it leaves a little bit of a dent, it's progressive, right? For the depth of the dent, I don't expect you to whip out a ruler and check. And then you have also beyond +4 is weeping edema, where, excuse me, there's literally no more space inside of a limb to hold edema, so it starts to like just weep outside of the pores. Your spine has a normal curvature to it. However, there can be different ways that the spine gets kind of twisted, as either you're born with like scoliosis, where the spine is off to the side. Kyphosis is that hunchback. You see that a lot in the elderly. As they start to lose muscle tone, their spine starts to go down on them. And then you could also have lordosis or swayback, which is when that lumbar spine is really twisted. Or twisted in, so you get like the patient's really leaning back. Lordosis is relatively common in pregnant women because the weight of the baby starts to pull their abdomen forward, so their spine starts to compensate. But that usually goes back to normal after birth. Your brain, it runs your body. You are essentially just a motor system for your brain. There are 4 parts of the brain. Your cerebrum gives you your conscious processes. It's broken into 4 different lobes, which we're all relatively familiar with. Though those lobes do different things, from speech to memory to personality. They all work there. Your cerebellum, which is that little bit right on the bottom there that's not colorful, that helps with your balance. And then you have your medulla inside your brainstem, which is your deeper processes. That's your part of your reptilian brain. The way I like to remember that is the water boy, when he's, well, what makes a crocodile so ornery? It's the medulla oblongata. There you go. Things you didn't know you needed to know. Cranial nerves. I'm going to say that the most important cranial nerves that you need to know is 10, the vagus nerve. You should also be relatively familiar with number 2, the optic nerve, and number 5, the trigeminal nerve, as well as where's 7? 5, 6, 7, the facial nerve. The trigeminal and facial nerve control this part of your face and are usually involved in Bell's palsy, which can be a stroke mimic. The vagus nerve runs from your brain to your butt. And if you put pressure on it, it directly stimulates the parasympathetic nervous system, which drops your blood pressure and drops your heart rate, and is why a lot of elderly people then die on the toilet while trying to have a bowel movement. These come directly from the brain. They don't go through the spinal cord at all. You have a number of different reflexes. The first one being just deep tendon reflexes, right? When you go to the doctor and they whack you in the knee, deep tendon reflexes. Primitive reflexes are what we talked about: the grasping, the rooting, sucking, the Babinski reflexes. They're normal in adults, but in children, but not in adults. Usually those kind of go away. So if you track a finger across a baby's toes or baby's foot, they will have a Babinski reflex, right, where their toes flare out, but that's totally normal. That's not normal when it's an adult. Various components of the nervous system assessment. Okay, we kind of touch all of these during our general assessment, right? Because we're making sure the patient's awake. So that's consciousness. Are they oriented to person, place, or thing? Are they moving around actively? Are they speaking to you? Does their speech make sense, which is a sign of their thought? What's their affect, right? Do they remember the events leading up to whatever happened? All of those are good. You should, the dermatomes is like the spinal cord tracts that come out. This is really helpful in determining where a potential spinal cord injury is. We're going to talk about this more when we get to trauma, but these 4 are probably the most important ones that you see that tend to pop up on tests. So they'll say, oh, you have a patient who is not, can't feel their body from their nipples down, where do you suspect the spinal cord injury? T4. Delirium versus dementia. Dementia is a gradual deterioration of your cognitive functions, whereas delirium you can have delirium on top of dementia, but most of the time delirium can be caused by almost anything. It's some sort of insult to the brain that causes confusion. Can be fixed if the underlying cause is found. We're going to talk about this more in cardiology, but here's a quick preview. We use this as our monitoring devices for cardiology. Things that we also happen to use, you're not going to worry about any of these blood tests except for blood glucometry and your capnography. There we go. The rest of them we do not currently have in practice. Always reassess your patient. When I was taught it, it's to do 5, right? Do your focused exam with your ABCs and your AVPU. Do it. Reassess your interventions. Take your vital signs. Retake vital signs every 5 minutes for unstable, every 15 for stable patients. Cool. Which math questions were you asking about?
That's right. Let me see.
Because I might already have made a video going through all of it. So I might just send you the video.
Well, the one that I was having a hard. Oh, that'll be good too. But the one that I had a hard time with was the one from Scott's email.
I did not get that email.
Scott sent out an email with a bunch of questions on it, and then the breakdown of how to do the problem.
Okay,
he didn't put the answers. That's
how about this? If somebody forwards me that email, I'll do all the math and I'll bring you through it step by step and give you the answers, and I'll send you a video of it.
Ooh, that'll sound good too.
Cool. So yeah, so forward me that email, and I'll do that, and I'll get that to you within the next couple days. Awesome.
In your email.
Okay, thank you, Natasha.
No problem. Thanks, guys. All right. Any other thoughts, questions, or concerns before I go jump on an airplane?
Where are you going?
Nebraska.
Have a safe flight.
Thank you. Going to go do critical care. So
are you actually going to land, or are you jumping out of the plane too?
I don't jump out of perfectly good airplanes. That's my pretty solid rule I have for myself. Stay in the airplane. All right, guys.